Right. So our first session for tonight is going to be a session that we're actually going to talk about hormone treatment in some detail, but it's actually for anybody. So whether you're prescribing hormones or not, whether you're a psychologist or a social worker, whether you're a nurse, or whether you're just a clinician who might see patients in your practice that might be taking hormones. So this is sort of the broad brushstrokes of understanding how that works. And I thought a good way of doing that would actually be to take you through the informed consent process that we go before we start a person on hormones. So before we would start either the masculinizing or the feminizing hormones, we have very good information leaflets, and I'll show you where one can find them, that we use to discuss with our patients. And I'm actually going to take you through all of these sort of key things we tell our patients before we start them on treatment. I want to talk just in terms of gender affirmation, just as part of our introduction, just talking around depathologization, that word, depathologize. And I just want to put right in the room here, before we start talking about gender affirmation, to understand that there's a very strong rhetoric, not very strong, that's the wrong word, very loud, very small people, but sometimes very loud, trying to actively undermine the rolling out of gender affirming treatment. And I just want to talk a little bit to that in a couple of slides. And if you look back historically, we saw that with our gay and lesbian people as well, is that the way the rhetoric has happened from people who struggle to sort of they're just not aligned with the LGBTQIA plus communities, would often try to describe people, gay or transgender people, for example, as immoral or as wrong, and quite often it's based on their particular church or culture or ideology. And then what tends to happen is it takes one little step then, and this happened also with people who are homosexual, that from the immoral and wrong, when they sort of realize, okay, well, these people clearly are something that it's not a choice, that they then get defined as being either pathological or deceased or mentally ill. And this has been one of the challenges we've also had with homosexuality. But what's interesting is how this then gets linked to the concept that gay or transgender people should not have human rights. And that is the big thing that this training is specifically trying to emphasize. So that means that there's communities of people who consider transgender people immoral or pathological, that do not believe that transgender people should have the right to autonomy or self-determination, and believe that they should not have the right to accommodations. So we talked about ethics in our last talk. And when we talk about ethics and accommodations, we talk about how do we make sure everybody has a seat at the table to create these truly inclusive, diverse communities. And the kinds of accommodations that I mean, for example, for our gay population, is same-sex marriage would be something that they have fought for, that they also want to have the ability to, for example, marry. And those laws are being re-looked at the moment. Bizarrely enough, we have a separate law for when a man and a woman marries than when two men, for example, marry. But for transgender people, the accommodation that's being asked for is gender affirmation. And this is seen as part of the human rights of providing inclusive care for transgender patients. So when we talk about providing healthcare for transgender people, we also talk about general healthcare. They also get diabetes and heart disease and acute illnesses just like anybody else. But then we spoke specifically about gender-affirming healthcare, and there are lots of different ways, things that we talk about when we talk about gender-affirming healthcare. So most important, actually, is the social gender affirmation. So that's very, very simple. When somebody comes in your room, if you use the name that they have chosen, if you use their pronouns, for example, you're using the pronouns that is for their gender, then that is affirming that patient for who they are, providing mental health support that affirm people, giving access to things like voice and gender expression. So we talked last time allowing a transgender girl to wear the girl's uniform, for example, and all of these non-medical gender affirming practices that people do to help live their gender is all part of social gender affirmation. And in our clinics, we also do that every time we just use the correct pronouns. Then medical gender affirmation, which we're going to focus on today, is talking about hormones and either masculinizing or feminizing hormones. Those are your two options. And then there is surgical gender affirmation, and there's so little access to it. I'll talk a little bit about that in terms of what we mean with that. So these are slides from from our previous session as well, and I just wanted to reiterate them here because it's a little bit just to bring again the evidence base around gender affirming healthcare. And I think what's important to understand, and that's why I started off with talking about this sort of anti-trans rhetoric that's going through, is that what the anti-trans, they say, no, this is immoral, therefore it must be pathological, and no, there's no evidence for gender affirmation. And it's just to be very absolutely clear, there is a extremely large body of very good evidence on gender affirming care. What there isn't is fancy, large, randomized, double-blind controlled studies with huge numbers of people. And as we said last time, for certain kinds of interventions, especially when we're looking at our transgender youth, for example, it's not appropriate to do RCTs. So on children especially for rarer and more uncommon conditions, you cannot double-blind children in cancer studies, for example. You certainly can't double-blind children and put some on hormones and others not on hormones. So no, RCTs is not an appropriate way to research gender affirming care. But there are a wide range of prospective and retrospective cohort studies, qualitative studies, cross-sectional surveys that actually builds up a body of evidence. The other thing is that, of course, transgender people is a very small population and they are spread out. So in a school, you might have a handful of people. You might have only a few in a community, and many of them might not actually even be out or accessing services. So to do research where you have huge numbers is not going to be possible. And so studies are always tend to be smaller groups, and there's always challenges in recruiting and sampling in very vulnerable and marginalized populations. And so what we've seen with the politicization of evidence, so to speak, is that there's this idea that no, because there's no RCTs with huge numbers of people, there is no evidence. And just to be very clear, actually, we have an extraordinary body of evidence for gender affirming healthcare. And I mentioned this last time very excitingly. There's a rapid review that's just been published in South Africa. The preprint is out and available. We will soon be having the actual study printed in the HIV Clinician Society guideline. An extraordinary amount of scientists has been involved, and they've looked at all of so our guideline came out in 2021. So that was based on the evidence we had at that stage. And this one they just focused on transgender youth between the ages of 12 and 18. They looked at all kinds of gender affirmation, social, hormonal, surgical, you name it. And you can see there was over 200 primary studies, 29 academic systematic reviews, and 4 grey literature systematic reviews. And what's extraordinarily clear in the evidence is the evidence doesn't contradict itself at all. All of the evidence is very clear. They all say exactly the same thing. So although all the studies are smaller and none of them are RCTs, they all have the overwhelming confirmation that this does good. So when we gender affirm people, there's a decrease in depression, a decrease in anxiety, lower odds of depression, and very important, a lower risk of suicidality in that population. There's improved quality of life, there's improved social functioning and a sense of belonging in community. There's reduced risky behaviors such as substance abuse behaviors and self-harm. And importantly, from a sort of the healthcare public health point of view, there's an increased access to healthcare services and an improved adherence to HIV prevention studies, and literally linked to improved viral load suppression. So we know that respecting, validating, and affirming a patient's identity improves outcomes for our patients. And also this makes sense. So in psychology, we know if somebody comes to you with strong inner experiences, it's extremely important to listen to what people tell you and to affirm and believe them. So in psychology, if somebody comes to you with depression or with strong feelings of insecurity, you have to affirm that you hear what they're saying and what they are experiencing to be able to actually help them thrive. So in the sort of old models, there was therefore a big emphasis that the healthcare worker was now responsible to decide whether somebody is ready to go on hormones. And we have moved away from that gatekeeping model to what we call an informed consent model, as is practiced in the rest of medicine. So the gatekeeping model was very much based on the fear. Hormone therapy was considered as this dangerous and irreversible thing. Everybody was very worried that clients is going to regret their decisions, they're going to have side effects. And so the clinician had this big responsibility. Am I doing the right thing? Is this person really transgender enough? And so there was this whole strange set of metrics where people had to try and prove that, verify their identity. This was very stressful, both for patients and for clinicians. What we now work on very strongly with is an informed consent model, and that's how medicine works. So under the HPCSA autonomy guidelines, the idea is that human beings can make autonomous decisions about their own health, and your role as a healthcare provider is simply to provide them with the necessary information. So the idea is we want to empower our individuals and uphold their autonomy. And the way the consultation work is you and the client are collaborative partners. And it's very similar to when we do our contraception consultations, right? The patient's coming to you, they're a healthy person. This is something that helps them for their lifestyle and the world that they live in. And so you as a healthcare worker inform them, and that helps the client to make a decision on what they need to do. Informed consent is always an ongoing process, and so you will keep on revisiting it, follow up, and you will see hormone changes is very slow. It takes years. So this is not like a tattoo where you make this change and then that's it. It's very much something that there are lots of opportunities to revisit this conversation. And then you have to document. So because the patient is going through all of these changes, and it's very similar than if you're going to do a termination of pregnancy, or if you're going to do a tubal ligation, or if you're going to do a vasectomy, those are all scenarios where you give the patient the information, and the patient has to sign informed consent, and you just make sure that you've documented that. It is important to realize that within that consultation, there is a huge unequal power relationship. And that does make the consultation sometimes a little bit more difficult if you've got somebody who's very, very vulnerable. So remember, we talked last time about those things that can put us closer to the center of power. And the challenge here is that the transgender person has no power to make decisions around policy or accessibility or whether or not they can get this treatment. They're completely dependent on the healthcare worker in front of them deciding to provide care or not provide care. And we need to understand that power is there, and therefore the transgender person might feel very compelled to try and say the right things so that they can qualify. So we really need to break that the old gatekeeping model and say, no, I'm just going to give you information. In the end, all of this is going to be both your decision and your responsibility. So the participatory approach places the transgender and the gender diverse person in the center of the consultation. Who are you and what do we need? And all of us around them are therefore just there to provide and support that process. In the minimum, you need the doctor, and then you can involve other people in the team to provide additional support for this person on their journey. But in the end, this person is sitting at the center of this process. So, of course, to have informed consent, you need to be sure that they have capacity. With people over 18, you don't even need to blink. It's a very simple informed consent process. In terms of youth, children between 12 and 18, and we are mainly focusing on adults in this particular training. Of course, under the law, children over 12 are able to consent for medical procedures where benefit outweighs risk, and they do have the capacity to consent. So just like they can consent for an HIV test, they can consent for contraception, they can consent for pregnancy tests, for example. They can, on paper, consent for hormone therapy. But just like we do with all of these other reproductive and sexual health rights, we need to make sure that children are, and that we have properly given support to our children in terms of making these decisions. So with adults, you don't really need the multidisciplinary team unless in some patients you might involve them, but it's not usually a requirement. In those under 18, I would always involve members of the multidisciplinary team to help support the child with those decisions and help us all decide if benefit outweighs risk. Person obviously mustn't be psychotic, they mustn't be under the influences of substances, and they have to be able to understand the risks and benefits. So you need to make sure that they're not in an emotional state and that they're able to rationally understand everything that they've been told and make a rational decision. So we have to then provide comprehensive information. And probably the biggest thing here is actually to manage expectations. So usually by the time people have come to your office, they've done lots of reading and they are they've already got all kinds of ideas of what they think is going to happen when they go onto hormones. And it's very important to make sure that we're very clear about what hormones can and cannot do. And then obviously we have to talk about potential risks, side effects, and complications. I'll just say a couple of words about people with intellectual or developmental disabilities. And here specifically in the transgender world, there's quite a big overlap between people who have autism and people who are transgender. So we see a lot of autistic people who are also transgender, or a higher percentage of autistic people. There's different ideas on why that is. It might not be to do, it might more to do with also that autistic people present more to healthcare services and are more likely to therefore talk also about things like gender. But very important is that people with, even with people who are challenging, and even people with who have autism that have high support needs, they still have the same rights to autonomy and the same rights to be engaged. And so here, an individualized, person-centered approach is very necessary. And it's very important here to also involve your multidisciplinary groups. So capacity also can be very varied. So one can't just say, oh, no, actually, they have this particular disability and therefore they cannot give consent. There's varying degrees, and part of the team needs to make sure that we actually make that decision. So if you have somebody who has a disability, and then please involve, again, your multidisciplinary team, and involve somebody from the mental health team that actually works with those kinds of disabilities. And what we again want to do is we want to really help them understand what their own goals are, what they are imagining. And you might take more time in terms of really giving them a good explanation of what the different options are, and also before one makes a decision on something like hormone therapy. So there's some of the communication things we specifically recommend when you're working with people with disability. And I think these are also just very sensible generally when you work with any person. So obviously always see what their level of communication needs are. Not everybody's going to have the same level of scientific understanding when you're explaining how your hormones work. Obviously, speak directly to your client and use very clear, straightforward language to not be ambiguous about what can or cannot happen. It's very helpful to have very concrete examples, visual imagery, practical demonstrations where possible. And it's always good to regularly check, did you understand that? Do you want to say back to me what you've understood that? And make good summaries of what you've just explained. So it's a little bit to get away from our tendency to just go through a little, we have our set little speech that we do, and then we move on, and being able to check that there is actually understanding before we start somebody on treatment. So let's just look at the informed consent process. And I'm going to first just look at the informed consent that we do with both the masculinizing and the feminizing treatment, because there's actually some things that are the same. And then we'll look at the two treatments in specifics. So just a couple of myth-busting things. Very important, you don't have to be on hormones to be transgender. So not all transgender people take hormones, and being on hormones doesn't suddenly now validate you as being transgender. Some transgender people simply